Hello, folks, and thanks to everyone hopping in. We're going to give people a couple more minutes just to filter in, and then we'll probably go and get started around 12:02-ish, I would say. But feel free to go ahead and introduce yourself in the chat box below. All right, I think we're good to go ahead and get started. So I just want to go ahead and welcome everyone to our last webinar in our Countdown to Orlando NTI webinar series. Today we'll be talking about creating a model strangulation response protocol for your jurisdiction. Can we go to the next slide, please? Thank you so much. Just a couple housekeeping items before we go ahead and get started. Just so everyone knows, this webinar is being recorded. It will be shared on YouTube after the webinar concludes, and also will be shared in a follow-up email to you all. If you are having any technical issues, please feel free to go ahead and message. Apologies for the incorrect info, but you can go ahead and message either NCVC Communications or Robin Evans. They should be in your participant list below, and they will be able to go ahead and hopefully help you out to the best of our team's ability. Next, there will be attendance certificates provided upon completion of the NTI webinar evaluation, which the link is provided for there. We will share the link as well at the end of the webinar and pop it into the chat at some point as well. However, I do want to note that we are able to provide attendance certificates. We are not able to provide CE credits. This is just a straight up certificate saying that you attended this webinar. If you need it, live captioning is available. Oh, sorry, can you go back for a second? Thanks. Live captioning is available for those who need it. You'll see it at the bottom of your screen with the button that says show captions. So you can go ahead and click on that if needed. And then lastly, we do ask that if you have any questions, please put them in the Q&A box and not the chat box. The chat box will not be monitored for questions. So if you have any questions, please put it in the Q&A box. It should be right next to that show captions button at the bottom of your screen. Okay, awesome. And then one quick last plug. As I mentioned, this is a webinar series leading up to our annual conference, the National Training Institute, which will be in Orlando, Florida from September 3rd to the 5th. You can go ahead and scan that QR code for more information on tickets and other exhibiting and sponsorship opportunities. Tickets are available up into the conference, and you can also learn more just by going to our website, which is victimsofcrime.org/NTI. And with that, I'm going to pass it over to our lovely presenter, Caryn Burton from the Indiana Coalition Against Domestic Violence. Thanks, Caryn.
Thank you, Krista. Thank you so much. I just want to say a quick thanks and shout out to the NCVC team for setting this whole process up. We were having a quick conversation before while we were all kind of getting all of the tech worked out. That I think that this is such a cool way to bring other possible workshop or session opportunities to folks who either maybe can't join us in Orlando in a couple of weeks, or to be able to put out some additional content, because as a previous conference organizer, that is one of the nightmares of conference organization, is going through all of these fantastic proposals for workshops and just having to really buckle down and say there's only so many hours in a day and only so many hours that we can expect folks to be able to attend sessions. So I really appreciate the opportunity to bring this session in a different way. So hello, everybody. My name is Caryn Burton. I am the Homicide Reduction Strategies Coordinator for the Indiana Coalition Against Domestic Violence. That is a mouthful of a way to say that I get to spend all of my days and time trying to figure out ways that we can reduce the skyrocketing numbers of domestic violence or intimate partner violence related fatalities, particularly in the state of Indiana. And so my days are spent typically working on our fatality review team initiatives and some of the other projects that fall on that scale. I've been at the coalition for a grand total of about 18 years. Prior to the position that I hold now, I was the training coordinator. So as I said, I spent a lot of time organizing conferences. So again, greatly appreciate this opportunity. I see everybody is continuing to stick their identity or their information in the chat, but if you would go ahead and do a quick poll for me, I am going to just do a quick understanding of who is in the room. It gives me a quick at a glance. And because this becomes an important part of our conversation around who needs to be at the table when you're talking about a model strangulation protocol. So if you would just very, very quickly click the option that most closely matches your role or your position description. I know there are probably a couple that are not on there. I've seen a lot of folks from probation who are joining us in the chat. A lot of folks who are over who are maybe working for the county, working for a collaborative effort, something like that. So if you want to go ahead and pop that in the chat, give us a quick indication. I do see some of my friends from the Indiana area. Natalie Coffey, I see your name on this list. I see one of our friends from Carmel Police Department. Hello and welcome to my Indiana colleagues. This is awesome. All right, give you another quick 10 or 15 seconds to just respond there. If your information is not, if your option is not there, it's not reflected. If you want to pop that in the chat, state administrative employee. Now be careful, no fighting in the chat over Hoosiers or Boilermakers. I myself am a Bulldog from Butler University, so I can accept a Hoosiers shout out. All right, let's go ahead and close that chat and see who all we have here with us. All right. And Dash, I don't know if you can pop up the results just so we can kind of see a quick breakdown of who all we have. Ah, fabulous. Vast majority, over half, advocate or victim assistance. Awesome. Welcome to my advocate friends. We've got some prosecutors, mental health providers. Others, I'm assuming we had things like, again, probation, things like that. So our advocates, fantastic. Okay. Another important question when we're talking about creating the protocol around strangulation is this one. Where do you fall on the scale of expertise? What's your experience along the strangulation expertise spectrum? Everything from, don't you mean choking, to, hey, I'm the one who does all of the training. So we can pop that poll up for our participants. That just really helps know where are the spaces where we might need to fill in. I have a tendency, and I know many of us do when I train, I kind of speak to where I know folks are. I try to where I know folks are in the room. Let's see. Fantastic. Okay. So we have a variation, everything from I'm familiar with the dynamic up to we've got a couple of folks who are the primary trainers. Awesome. And really what is important to understand is that the reason I ask this question is because when you are starting to work on your protocol, understand that you are going to have everybody around the table. You are going to have everybody of all ability levels, all education and expertise levels around that table. And they're going to be folks who may be in different from what you would expect. And so one of the conversations that we have around the model protocol is, even if you think you've got a group of folks who everybody in that room is at least, has done multiple training sessions, start to work toward the understanding of getting everybody at the same level by attending the same trainings or getting the same information. Making sure everybody's on the same page, working from the same book becomes a critical component of working through your protocol process. So I am going to start this conversation, and ironically, I just saw at least one of the people who are on this list actually join us. So I love being able to see who all is joining us from where. I have to first give all respect and acknowledgement to the members of our domestic violence fatality review team. We have in the state of Indiana a domestic violence fatality review team that reviews fatalities for the entire state. And they have been the driving force. They have been the secondary and the extra drivers who we've cycled through on this process. And so I have to acknowledge all of those folks who are on this list. It's very small and hard to read, but those are our current and former members of our fatality review team who have been my co-authors, co-workers, and co-drivers on this process. But I just want to talk a little bit about what to expect today as we go through this content. The content was originally kind of put together and drafted to be a conversation, so that in a room full of folks who are all interested in doing this thing, we could strategize together and we could brainstorm together. And so having to pivot that a little bit, I'm going to talk about what our process was. How did we originally come up with this idea? How did we work through the process? What were the barriers and challenges that we had? What did we find effective as we were creating this protocol, drafting it, and then getting it out there and trying to work towards implementation? So all of that becomes a part of this process, and we'll just walk through that path together. When I talk about strangulation, I think it's really, really critical to start from a place of understanding why a collaborative model is so important. We know collaborative models across the board are considered best practice when we're talking about intervention, and particularly around domestic violence and intimate partner violence. But the reason why a collaborative model when we talk about strangulation is so critical is because strangulation itself is a different form of violence. And by that, I mean the trauma that is laid down upon people, the effect of that trauma in terms of the long-lasting medical and physical effects, but also the emotional and psychological effects of that trauma and the way it plays out for survivors. But it's also really important to understand that the way that partners who cause harm, who use strangulation, view the harm that they cause is different. This is a different breed of individual who says, I am going to hold this person's life in my hands to get what I want, and I'm going to make sure that they know it. And so I start conversations around strangulation by looking directly at what those folks say, so we can understand why we have to be organized and collaborative and intentional in our process, looking for accountability as a part of our response. So for those of you who know what the Strangulation Chronicles are, the Strangulation Chronicles are basically a narrative website where a gentleman who runs domestic violence intervention, abuse intervention programs in the state of California will actually just ask those folks and say, hey, tell me about why you use strangulation. What were you thinking? What was going through your mind? What do you find effective about this? And these are the direct quotes from partners who cause harm who are going through an AIP, an abuse intervention program, for use of strangulation. And they say things like, it's the fastest way I know to shut down hours of bitching. And by that, I mean immediately. It's a no-cost hearing aid. She's never ignored me with my hands around her neck. We call it the squeeze play. In baseball, it's how you avoid getting tagged out. With your wife, it's how you avoid getting hooked up by the cops. I see it as a cure for feminism. It's the witness prevention program. This is how partners who cause harm, who use strangulation, who choose to use this form of physical assault, view the harm that they cause. This is their attitude towards it. So these are a different breed of individual. This is why we also know that these are the same kind of individuals who pose threats to law enforcement, who pose threats to the community in general, because they're the same ones who will decide to, for example, use a mass shooting event as a form of violence as well. That overlap is documented. And so we have to really understand that the common or the standard ways that we've learned to seek accountability, to provide services to survivors has to pivot, has to change a little bit. It has to be more intentional. It has to be more mindful of the trauma and the threat that can be done. So we know that strangulation is the #1 predictor of homicide and domestic violence cases. That is why a collective response is so critical, because there are so many aspects of these cases that can fall through the cracks. There are so many places where a case can be lost, can be a place where a point of contact is missed. And so having as many eyes on this case, as many supportive services around that survivor, as many folks who are looking to accountability for that partner causing harm, becomes a critical step in an effective intervention. And that's what we're looking for, is an effective intervention. I do see the question in the chat that says, will you please share where the information was gathered from, BIP application and or survey? I missed what the presenter said. My apologies. So those quotes were taken, and there is a website that's linked on the bottom, and you will get all of the materials, so you'll be able to see that website. But it's strangulationchronicles. I believe it's .com. And it's if you just search Strangulation Chronicles in your website, in your web browser, that should pull it up. But there's detailed information on where he gets that information, how he goes about gathering it. But it's an intentional process as a part of the intake when he is bringing partners who cause harm into his abuse intervention project group. So hopefully that answered it up. Somebody popped it in the chat. Thank you so much. Just a note quickly, I know we all know the lethality statistics around domestic violence, around strangulation. Victims of non-fatal strangulation are at a 750% increased risk of attempted or completed homicide. 700% attempted, 800%, or excuse me, 800% attempted, 700% completed. We tend to combine that and go 750. 68% of domestic violence survivors suffer strangulation as a form of physical assault. What I always find interesting is the difference between 68% of survivors who do suffer strangulation and 45% of homicides that have a recorded history of strangulation. The reason why I put recorded in italics there is because recorded is subjective, right? We know that very, very often survivors are saying, yes, this thing is happening to advocates, or they will say it to a victim assistant, or they'll talk to family or friends, or they'll talk to a medical provider about it. They're not always disclosing to, say, law enforcement or prosecutor if the incident in question does not have to do with a strangulation. So we kind of look at those numbers as a baseline and say that we understand that it's likely more common happening. It's just the recorded that is the qualifier, and recorded there is that was reported to law enforcement, was part of a prosecution charge. So, there we go. Oh, sorry about that. I'm skipping around here. Okay. So we start here with your strangulation statute. Every state now has a strangulation statute. Woohoo! That only took a grand total of about 20 some years between the time the first strangulation statute was implemented and the time that our last state actually went ahead and passed their statute. But we do know all 50 states now have a strangulation statute, and your strangulation statute is where you have to base all of your efforts. It's one of the places that will inform what does your training need to look like? Who maybe needs to be at the table, particularly in your jurisdiction? Our model protocol is for Indiana jurisdictions, so our model protocol is built around the Indiana statute, and it provides us guidance on how to train our prosecutors, how to train our law enforcement, and how to involve our advocates. But for some states, you may have a more intensive strangulation statute. And by that, I mean, when I talk about our strangulation statute in the state of Indiana, I get to talk about the fact that I love our statute because of what is not there. So for example, if you read through our statute just talks about if you do the bad thing, you do the bad thing. So if you apply pressure to the throat or the neck, obstruct the nose or mouth, or you commit what's called a compression suffocation, so you sit on the torso of somebody, that is strangulation. You do those things in a way that it impedes breathing or blood flow, that is strangulation under our statute, and therefore it is a felony offense. You can be convicted of a felony. Level 6 is our lowest level felony. Our numbers go in reverse order. So level 6 is the lowest level felony offense that you can have in the state of Indiana, up to level 1. Level 1 is murder in our state. So what I get to talk about is I love this in terms of what is missing. Some states are actually more definitive in their addressing of the issue. So they will specify there has to be some sort of bruising or visible injury. There has to be a amount of time that was expressed for it to qualify at a certain level. So that's going to inform that level of training and that level of conversation you're going to want to have around documentation. How do you do that? How do we make sure that everybody's on the same page and working from the same book? I don't have to worry about that because our statute literally says, if you do the bad thing, you do the bad thing. Now, where our prosecutors often struggle is the fact that it does define that if you impede the normal breathing or blood flow. So in most cases, what we are talking about is manual strangulation in some form or another. So if you have gone through training on strangulation, you understand that the primary modality of injury for strangulation is by cutting off the blood flow through the main arteries and veins on the sides of the neck. Okay, I can then have that conversation and talk about with our prosecutors, here's how you establish that in court. Here's how you can demonstrate that. Here are tools that you can use as exhibits to explain what doesn't logically make sense to a jury to make it make sense, right? Most people think strangulation, you can't breathe, and therefore that's the problem. Whereas the opposite is usually true. It's usually because the blood flow is cut off, and here's how you demonstrate that. And here are the people who you can call to explain that. And here's how you ask those questions. So that statute is really going to inform a lot of the conversations that you have to make sure that your team is ready to implement a strangulation protocol, is ready to take on all of the things that that means. So our protocol started. It became a nugget of an idea back in 2016. So this has been a 9-year-ish process from nugget of idea to realization and to implementation. This is a screenshot that was taken from our Fatality Review Team report that was published in 2016 that identified and evaluated and reviewed deaths that had occurred in 2011, 2012. So if you know anything about Fatality Review, you know we're always looking backwards in time for a lot of different reasons. But in 2016, our team, which was not even actually a state team at that point in time, reviewed all of our fatalities, and we really started to see that increase, that uptick in identified strangulation prior to the fatality. And so one of the things that we as a team put out as a recommendation was a strangulation response protocol should be a standard part of every community's collaborative response to intimate partner violence. That was the seed. That was where we planted that seed. And unfortunately, at the time, our fatality review team didn't have a lot of, didn't have really any authority or any ability to make those recommendations into actually implementable processes. So we had this great idea. Let's do a strangulation response protocol. We know this is important. We're starting to work with the Training Institute on Strangulation Prevention. We'd started to emphasize getting trained on the issues of strangulation because we were starting to see it as a critical issue that our survivors in the state of Indiana were dealing with, and that was related to our fatalities. But we didn't have the ability to really implement that. We could suggest it. We could make it a known thing. Hey, this would be a great idea, but we couldn't make it happen. So we started there with this idea that just kind of sat. And in the back of my head and what I was doing at the time, this was something that I really started to say, I need to look into this. I need to figure out how to make this happen. So from there on our timeline was kind of convoluted. There were all kinds of combining forces and interesting ideas that were happening and things that were moving forward that eventually led us to where we were about 2 years ago come October. So we started with the revision of our fatality review statute. And within the revision of our fatality review statute, we established the statewide team. Prior to 2017, we did not have a statewide team. We had the suggestion that regions or different communities could have a domestic violence fatality review team, and ICADV took the responsibility to help folks implement that. In 2017, we revised our fatality review statute to say we need to have a state team. We also included in the creation of that state team the ability and the responsibility to, where it was feasible, actually implement those recommendations. Basically, the legislation, the text of our legislation says that we will make recommendations and that we will take actions to make those recommendations more able to be implemented. So we were tasked with that specifically as the fatality review team. Our statewide team itself was named in October of 2019. Now you'll notice there's a 2-year gap there when I said, oh, we revised the statute in 2017. It took 2 years for the governor's office to name our team and for that to take place, for that to get implemented and actually to hit the ground running. The timing on that was all kinds of fun because we had the team finally named. We were ready to convene. Our first meeting was in November of 2019. And then 2020 happened. And so all of this energy and all of these great ideas that had been percolating about, hey, here are the things we're going to do. Here's how we're going to update our fatality review process. Here are the recommendations we want to start looking at to see, can we start implementing these from previous reports? We had all this energy, all this conversation around it. And then the world stopped and we did not meet for several months. And so all of that energy just kind of got bottled and sat there. But we did start meeting and the world started somewhat turning. And really one of the first conversations that our new fatality review team had was identifying that strangulation response protocol as our first recommendation to actually implement. So we started work on this project in right around December 2019, January 2020. So that's when it really started to become a thing that we were going to start to put our effort behind. And we honestly had no idea how to do this. All of the state protocols that had existed or that currently existed in that moment, the statewide protocols that existed were things that were completely supported in terms of coming from like a governor's task force or a state agency that has the power and authority and resources to say, this is going to be the thing that we're going to do. We are changing the way we address strangulation in the state of here. We don't have that in the state of Indiana. We had our small team saying, hey, this would be a great idea. What do we do? So we decided to really talk to the folks who we had already been working with. And by that, I mean, we had already hosted a couple of trainings with the Training Institute on Strangulation Prevention. We had already been talking about strangulation in different capacities and in different spaces. So we went to those folks and said, okay, what are the barriers? What's going to prevent you from doing this? What's going to ease the path to doing this? How do we approach this project in a realistic way that is ultimately going to help you, so that when we come back to you and say, here's a thing, you can actually do that? And many of them really said, it's just, we don't know where to start. The project, the idea itself, it's like eating an elephant. We all know the best way to eat an elephant, one bite at a time. So we started looking at what are the critical components that are present in these other statewide implemented protocols where they have done all of this work, they've done all of this legwork. How do we pare that down to make it not scary? Because I will tell you, one of the things that we did was we went out and we pulled existing implemented protocols, and we pulled protocols from different medical providers, different hospital systems. We pulled protocols from states that were implemented, and those protocols tended to be something like 150, 200 pages that had everything from here's how you log on to this tracking system to here's how you do all of these things. And here are the reporting forms that you need to use. And we're changing all of this. And here's the system that you're going to use and the protocol. And we recognized immediately that that could be a massive barrier. Is we don't have that level of access, but also B, that's really, really intimidating to slap down this like 200-page book and say, all right, here's what you got to do. So we really looked at it as we need to pare this down and make it digestible. And one of the places that informed this conversation was how we approach lethality assessment in the state of Indiana. Lethality assessment in the state of Indiana is not mandated. I would love it if it was. It would make my life way easier, but it's not. So the way that we have to approach it is community by community, jurisdiction by jurisdiction. And we have to create that collaborative response within those specific service areas. So we go to those folks and we say, here's the bare bones, here's the skeleton. Make it work as best you can with these specific things in place. These are the requirements. This list is the things that have to be present to make it useful, to make it effective, so that can still be used in the way it's supposed to be. All around that, you can plug it in, you can play with it however you need to. And so we took the same approach with strangulation protocol. We really went to our folks multiple times and said, what needs to be there? What doesn't need to be there? What's going to scare you away? And so we really wanted to be very responsive with how we did this. We started with some work that we had already been doing in Marion County. Marion County, Indiana is the count. It's the center of the state. It is the home of Indianapolis. And Marion County is one of our most populous cities, one of our most populous counties. It is the home of multiple service providers, multiple law enforcement jurisdictions, all kinds of those factors that can be the difference, that can be the obstruction to any type of collaborative protocol. And we kind of looked at it and said, okay, if we can work from what they've created in a way that they think will make it work for them, then we can address those questions before they're asked. We can look at it and say, here are the ways that you can collaborate in a way that works smoothly where you have jurisdictional issues, because we knew that would be a problem. So we started with Marion County and work that they had already done, and we brought those folks to the table. We pulled another 8 to 10 published protocols or protocol-like documents. And by that, I mean, there were protocols that existed for, things like an LAP collaboration that then grew into a strangulation, or things like a DV high risk team model that had a strangulation component to it. So we pulled all of those documents and said, where are the through lines? What are the commonalities? What are the things that all of these have present? And what do we want to build into ours? So we had permission and we got a hold of the public access documents. We looked at variations of it because that was going to give us a full rainbow of kind of colored approach to it, right? We worked together on doing those reviews for about 18 months. So that was a significant chunk of the process. Once we'd done all of that, we kind of sat down and said, let's draw our skeleton. Let's create our structure and our outline, and then we'll fill in from there. And then, as my friend Dory says, you just keep writing. You just keep writing. And writing that protocol was a heavy lift. So again, I always give all thanks and acknowledgement to my Fatality review team members who assisted with that, because writing that was a heavy, heavy lift. And so you have to really have one person or two people who are going to take the primary responsibility to do that. Because if you don't do that, you have a really disjointed approach and a really disjointed document that doesn't have a common voice. And that common voice will get called out. We had a couple of pieces that were reviewed early on in the process, and we kind of cobbled them together as one document. And we had multiple folks who we went back to and said, hey, take a look at this. How does this land? Does this work? We had multiple folks who said, it doesn't make sense because it's written in all kinds of different ways. Like the writing is different in each section. So one of the things that becomes really important is having one author or two authors that can really work together so that when you create your final document, it has a singular voice. That helps avoid kind of, confusion and just making sure everything is clean and clear. And where we ultimately got was here. This is the Model Collaborative Strangulation Response Protocol for Indiana jurisdictions. And I actually I'm holding up, hopefully it's coming through on the camera because I know sometimes that doesn't do it really well, but this is a hard copy document. And that was one of the first conversations that we had is, do we put this out in hard copy? What does this look like? And the answer that we came up with was yes. We have to have something that we can put in people's hands. We have to have something because we know folks, break down information. They look at information differently. Different folks have different processing abilities or different processing ways. And so we wanted to create an actual hard copy document, at least at first. And so it was published in hard copy in 2023, October of 2023 was the end of that 7-year creation process. From seed planted to actual document was about a 7-year process. And that's what came out of it. And I will tell you, after that was done, man, it felt good. It felt good to get a box of things that said, here are all of these documents. So we wanted to make sure that we had something that we could deliver, and we did deliver it. We published it on our website with a full appendix of templates and model documents and other resources, which was a critical component to it because not everybody was going to be able to get a hard copy. Even now, when we go and do trainings with our Emergency Nurses Association, which I'll talk about in a minute or two, we still will take hard copies with us, but we don't take all of them. So we give them, here's one for your agency, here's one to be shared. But we also create specifically, it is accessible online because folks got to be able to take it. And if we want them to plug and play with it, then they got to be able to plug and play with it. So it's a PDF document with an appendix of resources that exists. And we regularly revise that appendix. We add things in. For example, one of the things that's critical within that appendix is a list of what hospitals and medical facilities have forensic nurses on site at all times. That is a critical part of that because we talk about the forensic exam being a part of a strangulation response protocol. So we put in there the updated list, and we have a contact at our Forensic Nurses Association who provides that for us. So that is consistently updated. Anytime we get a new model or a new template for a law enforcement report form, hey, this law enforcement jurisdiction just revised their form. This is what they use as their strangulation supplemental, or they have included strangulation in their standard response template. Great, add that in there. That way, as jurisdictions are looking, as different organizations are looking, they can go in there and see what's already there. They don't have to rewrite an entire document. They might have to reprogram their entire online system. Can't help with that, but I can at least give you the bare bones of the document to use. We also made sure to send it to the folks who have helped us along the way, and those are the folks at the Training Institute on Strangulation Prevention, Gail Strack, Casey Gwynn, Dr. Bill Smock, their whole team there. Have been absolutely wonderful in kind of advising us through this process. And we made it a point to send this to them and say, hey, this is what we've created out of all of the work that we've done. We also made it a point, almost all of their stuff that they put on their resource center is public access, but we made it a point to get permission to say, we're going to put this in our document and it's going to be accessible on our website, clearly labeled as a product of. But we greatly appreciate, we just want to make sure that you are okay with that. You don't want us to just link to your website because we want to make sure we're honoring the folks who have already done work that we have taken in and helped make our own. Also had some really great conversations with Gail and Casey, especially in terms of the work that we've done. We worked with them on their Facebook Live sessions that they do to have a conversation about creating this protocol and what it looks like and what our process was. We also built into our process, and I feel like this is a really critical part of the conversation. We built into our process revisions and updates. We knew this was not going to be a static document. It can't be. Our legislation may change. Guidance and statistics are going to change. Training is going to be updated. So this cannot be a document that is anchored in 2023. It cannot not move from there. It can have a root there, but it's got to be able to grow with what we learn and what we find out and know now, as opposed to what we knew in October of 2023 when it was published. So we built in a process to revise and update. We are actually going to be reviewing it in 2025 and identifying, are there things that need to be changed? Are there things that need to be updated, with a plan to republish online in 2026 Q1. Because it is a collaborative protocol, we worked from there in making sure that what were the pillars that we needed to involve. It has to involve survivor intervention. So we have to talk about victim advocates and victims assistance. We have to talk about offender accountability. Accountability where strangulation is used is key. These are individuals where accountability has to come from a system because they've already inflicted enough terror and trauma on the survivor and on anybody else who's associated. So accountability through the system has to be a part of the process. Prevention of further violence is always going to be one of the goals, but that is a key component to collaborative response to a CCR ostensibly. And so we want to make sure that everything that is in there is anchored towards we're preventing future violence, specifically preventing future homicide. A piece of it has to also involve education of all of the systems to that focus area. So specifically here, education of all systems around the dangers of strangulation. And so using the conversations that we have, using the training opportunities, using things like when I go testify in strangulation cases, here are the ways that we can use that conversation to make sure that everybody's on the same page. I see the question, were tribal nations included? In the state of Indiana, Indiana does not have any federally recognized tribal nations. Now, that's a short and crappy answer to that question, specifically because Indiana is also the actual tribal home to multiple tribal nations. And so we have a presence here, but we do not have any federally recognized tribal nations. So the short answer and the crappy answer to that is no, they were not part of the initial conversation, but they are on the list of, now that we have this in place, that's one of the edits that is looked towards for this next system. That's a really good question to ask. Thank you. The last piece of a really critical the really critical components to a CCR is that making sure that all of those aspects that are included in your protocol are actually implemented. So if you implement a protocol that includes law enforcement, prosecutor, and DCS, Department of Child Services, all three of those things have to actually go through the implementation process. Otherwise, it leaves gaps. If that was your initial plan, now you can evaluate it and say, hey, this isn't working, we need to pull this back. That becomes a part of that follow-up process. But all of those aspects have to be included. So who's at the table in our protocol? Who are the conversations? What are the conversations that we have? Law enforcement, advocates, and victim assistance. It's important to realize that those are actually two separate things for us. For our jurisdictions, advocates, meaning nonprofit, shelter, non-residential, those advocates that are supported by VAWA programs, things of that nature, and victims assistance, meaning systems-based victim advocates, those advocates who are housed in law enforcement and prosecutor's office. In the state of Indiana, they are two separate things with two separate levels of confidentiality, two separate levels of involvement in the process. But it's collaborative, and it has to be. They should work in complement to each other. And so we made sure to kind of address it as two separate things with the eye towards them being a single process, which is an interesting way to approach it, but it's true. Emergency medical services. So whether that's EMS, whether that's your local ambulance service, whether that's your local ER department, whatever that looks like, who is going to be providing those emergency medical systems and processes to that survivor? Forensic nurses are a key part of the process. In the state of Indiana, unfortunately, we do not extend use of forensic exams for domestic violence cases unless there is a component of sexual assault in general. Now, there are certain health departments or there also are certain hospital systems that do that. Most of them do not. So our approach has been to work with forensic nurses with an understanding that because of the overlap between sexual assault and domestic violence, many of them are going to be involved in this process anyway, but a part of the response becomes making forensic exams available in cases of intimate partner violence that do not have a sexual assault component. So that becomes a part of that collaborative response building to make the response protocol as effective as possible. Obviously, your prosecutor, and then you see there those last two arrows, coroner and Department of Child Services. Those are ones with a specific level of interest in our process. We are looking to prevent homicide. So involvement of the coroner's office is limited typically. In other areas where the coroner has a greater level of involvement in whether it's prosecution, functioning as an expert witness, whatever that looks like, that might look differently. And so making sure to kind of who are going to be the critical components at your table that might need to be added to this conversation. And then Department of Child Services is always one that we try to be very, very intentional about, because there can be such a tentative, bordering on what feels like dangerous to survivors, relationships between Department of Child Services, between survivors, service providers, advocates, and victims assistance, things of that nature. And we want to be very, very intentional, but we also recognize that DCS has an incredible ability to provide services where some agencies may not be able to. They may already be involved in the case because there is domestic violence. In the state of Indiana, it's a weird legal relationship in terms of domestic violence, Department of Child Services where domestic violence is involved if children are present. And so that's a whole kind of conversation that we had to have. But we know DCS can play a very important role depending upon your relationship and what their responsibility is in your jurisdiction. So just a few kind of quick things around who is involved and what their role is. I put this information in here just as kind of an anchor component because I wanted to make sure it was in there and what we were looking at being involved in the process. So we put law enforcement's role in there, making sure that all department divisions are involved, making sure everyone is trained on identification, investigation, documentation, follow-up that's needed, making sure to link the investigation and medical provision, medical care provision, making sure you're getting medical records that are going to back up any information that or answer any questions that may be there. And then advocacy as it's linked to law enforcement, but making sure that it is not directly related to, meaning that the outcome of the investigation cannot be the key to the link for survivor to advocacy services. It can be a part of it, but it shouldn't be the only part of the access. As I said, victims assistants and victims advocates, making sure that that is a complementary process, and understanding that regardless of if strangulation was a part of the initial report, that we identify as advocates, is this something that they have ever experienced? Do we need to encourage medical care as a part of a safety plan? Do we need to be aware of the effects of acquired brain injury in terms of how we work with them as advocates? Do we need to understand that there are certain requirements that they may need, certain accommodations that they may need, specifically because of the injury due to strangulation, even if it wasn't a part of the initial report or the initial contact? And then I always encourage, for particularly victims advocates and victims assistants, that ability to work as an expert witness. Talking about domestic violence, if you're trained in strangulation and you are to that level of being considered an expert under your rules of evidence, acting as an expert in strangulation and domestic violence trauma can be really, really helpful. For our forensic nurses, again, linking to that forensic nurse exam or that forensic exam, so that even in cases where there is not sexual assault, they are still getting that level of examination and care. And also the link to forensic nurses as potential expert witnesses for prosecution. If you differentiate screening prosecutors versus trial prosecutors, making sure that as screening prosecutor, you are making your advocates, your law enforcement, everybody aware, what does this judge need for an establishment of probable cause under your state laws? And also talking about working with trial prosecutors to make sure that strangulation charges are filed and what might be necessary to back that up, to put that forth in a court. For our trial prosecutors, really it is, how do you establish strangulation per your state statute? What are the things you need to bring into the conversation to make sure that you are meeting the elements of the crime versus just saying, see, we know this happened, right? And depending on your state statute, that can be different. Like I said, state of Indiana, one of the conversations we have to have regularly with our prosecutors is, how do you establish that somebody putting their hands around their throat and squeezing actually impedes blood flow? Because that's the primary modality of injury. So having those conversations. And then again, putting the information in there about how you might use your coroner, how you might involve your Department of Child Services. I really just wanted to highlight a couple of things in terms of our appendix. As I said, the appendix is broken out into a couple of different spaces. If you access it via the QR code, which you will get, via the link, which you will get in the follow-up, this is what the protocol appendix looks like. It is broken out as clearly as we can possibly make it. There's access to training videos and resources, broken out to include a section on our legislation, so that we can put that information directly in there. And then the actual document broken out by different work collegial groups. Things in there under our advocate, like identification. How do you ask the question? What do you put in your law enforcement reports that will actually get to the elements of what we're trying to identify? Different assessment tools. This is one tool that is given for advocates through the Training Institute on Strangulation Prevention. These are all documents that we have linked directly. We have Esperanza in there so that trial advocates or trial prosecutors can access her, advocates can access her as a just an informational tool, being able to train your dispatchers on these are the things that you need to look for. Advocacy intake, different questions that can be asked to identify if this has ever been an issue. Also looking at one of the newest things that we've started to look at is the issue of I'm using consensual, in facetious air quotes, consensual strangulation during sexual activity, because we know that that is a massively growing issue where strangulation is almost considered vanilla as a part of sexual contact. But we know that that still causes a lot of damage, and that it's not a safe practice. So how do we have those conversations as advocates? Other things that survivors can use to document potential injury, and to be aware of the symptoms that are there, and then the trial tools that are present as well. This is a quick breakdown. This is how we have the conversation about what it actually looks like to cut off blood flow to the brain during strangulation and how that actually causes damage. The timeline, so that it is made sure to be put out there as far as this is one piece of evidence that we can talk to, is how we establish severe injury during strangulation, and how close somebody is to potentially dying due to a strangulation incident. When it comes down to implementation, one of the critical pieces is gathering feedback. Gathering feedback has to be a continual process. So we continue to work with, and as I said, part of the process was working with previous attendees at trainings on strangulation. What do you think about what we have created? What would make this easier for you to implement? Would this be something that your area was interested in having? But we also work with our survivor advisory board. ICADV has a group of survivors from different areas, different walks of life, etc., that we continually work with when we have things that we want to put out. We have processes, we have protocols we want to suggest as best practice, or we want to work on implementation. Our survivor advisory board becomes a key section of feedback to say, if you as a survivor had access to this tool or this thing, what would you want to see? How would you make it different? Would you want to see this implemented in your area? And then again, working on the Training Institute on Strangulation Prevention. We worked with, again, we took our hard copies, we sent them to the Indiana legislature. We announced it in all of our publications. We did direct outreach with as many allies and collaborative partners as we could, identifying those folks who were critical. So working with our Prosecuting Attorneys Council, we are doing collaborative training with our Indiana Emergency Nurses Association. We have done 8 of those trainings so far, and out of those 8 trainings, 3 communities have decided to implement the protocol itself. We also work with our lethality assessment protocol implemented jurisdictions to expand what they do as lethality assessment into a possible strangulation response protocol as well. So those have been key allies and key strategies in how we are expanding and implementing the protocol. The challenges that we've had have been really general in terms of not like specific, oh, this thing was a hard thing to overcome, but really it's just been the environment in which we operate. A lack of prioritization and a lack of apathy from our legislator, or an act of apathy from our legislators. It's not a priority for them. They don't see it as a critical component. So it's continuing to work with those folks to get them to recognize why this is such a critical thing to have, and how do we make it so that it's accessible for our law enforcement jurisdictions, it's expected for our domestic violence task forces, our sexual assault response teams, those things. Disparate agency response. We have some law enforcement jurisdictions that know and understand and see the link to strangulation, the link between strangulation and homicide. We have some that just, they don't see it. It's not a problem. It's not killing people, because what we see is when there is strangulation that ends in a homicide where it's present, the actual method or the actual implement of death is a firearm. So they're seeing the firearms and they see the link to firearms and the firearm access as a problem. However, what they don't see is that the strangulation is the warning shot. If we intervene appropriately with the strangulation, then we prevent the firearm death. And that's where the link, like we have a disparate agency response. And then there's always scarcity mindset. How do we implement this with funds? How do we pay for this? And it's not horribly expensive to do. It's really just investing the manpower and investing the time to change the expected response. So really how you do it, find your team. Who are going to be your champions? We have worked with some amazing people, some folks who are actually on this call. Amy Blackett from the Indiana Prosecuting Attorneys Council has been fantastic in terms of working. She's actually a member of our Fatality review team and fantastic in really generating ideas of how we continue to grow this. Where are your entry points? What are the points of entry? And it sucks to say it because as advocates, we hate to do it, but taking advantage of a situation where there has been a tragic outcome and walking in and saying, this is a place where this could make a difference. And I hate having that mindset and I hate having to look at things that way, but sometimes it can be an effective way to find a way in to make the change that needs to happen. And that actually helps you identify your pivot point. And then collective acceleration. Bring your friends with you. The more people are involved, the more people who have an attitude towards, then the more you are likely to be able to push things forward in a way that really makes the change we need to see. Our ongoing evaluation revision, as I said, is the key part of it. We're actually getting ready to start our revision. We know we published the document knowing there would need to be changes, the addition of a DCS section and a coroner section. We know we need updates on our forensic nursing section based on practice updates. We implemented with different jurisdictions and we've asked them, what are the ways that you would change this? And so we have ideas of where to go with it going into that revision and republication in 2026. So this is the last piece of information. That QR code will take you directly to the link in that Google Drive with our resource and appendix with our document. We want people to use it. We want you to take it and we want you to say, hey, we can take this, we can add pieces, we can subtract pieces, and this will be very effective. We actually had that happen in Puerto Rico. Puerto Rico actually called us and said, hey, we saw this. Gail Strack from the Training Institute sent us this and we want to use parts of it. Are you okay with that? Yes, please. Yes, please. If you want to credit Indiana, fantastic. If you change it such that you think it, okay, hey, I don't care. I honestly do not care. All I want is for jurisdictions, for collaborations to have the skills and have the base information that they need to take it and run with it so that we are appropriately addressing strangulation. If you want to credit ICADV, we'd greatly appreciate it. I'm not going to sue or anything, I promise. This is not copyrighted in any way, shape, or form. So we are right at 1 o'clock. I want to make sure I am honoring time. I know there were a couple questions in the chat. I want to go back and address those, but I want to make sure that I'm very aware of time in terms of folks have other stuff that's going on. But I want to say thank you to the team at NCVC. I know they have the evaluation, so I will put that up. This is the NTI evaluation for the webinar that will lead you to getting your certificate of participation, which they will be providing to you. And thank you to the NCVC team. And thank you so much to everybody for taking time out of busy schedules to hear about our protocols. So thank you so much.